The PPO didn't save her any money. This is a fiction. It's a house of cards. It will not last. It will not sustain. And more hospitals are getting a lot of public relations pressure to stop the crap. It's an easy article for any reporter to write. Go with someone that wants to pay cash at the time of service. Go with them to the hospital and see what happens to them. And if they charge some monstrous fee for a small service, find out what a PPO would have paid for that same fee and write it up. This is humiliating for people on hospital boards of directors. They cannot sustain it. It's an embarrassment. It's shameful. They got to get off it, and increasingly they are. Health plans are moving away from this whole PPO leverage discount to providing better customer service. Thank God at last. 17 years after I quit the blues for that very reason. There was just an article about United Healthcare. Its share price plummeted 49% this year. It is lowering its profit expectations that it's reporting to investors. This was actually before the financial crisis. God knows what the share price is now. Their share price dropped because they're getting less premium income because of high deductible coverage, but they have not changed their administrative practices. So instead of getting a $6,000 insurance premium per customer, they're getting a $4,000, they're getting $2,000 per customer less. But their administrative costs are exactly the same as they were before. Now, United Healthcare does not need all that administration in a high deductible environment. They don't need to process every $50 claim that comes through the door. 95% of all its customers will never break through the deductible. They will never get into covered services. United Healthcare should be not paying any attention to those people, never bothering them. And that way they could get back to profitability. And they're beginning to figure that out. So they're saying, well, our future is no longer enforcing discounts from providers. Our future is in better customer service. Thank God. The advent of low-cost retail drugs, the Walmart $4. Walmart says, and I take them seriously, that they actually make money at $4 per script on generic drugs. This is not a charity they're doing. They are making money on it. And it's not a loss leader either. They are actually making money on the drugs. Generic drugs are so cheap that when they're bought in quantity, they cost less than $4 per script. More and more patients are doing this. Someone, I shouldn't say because I forget where it came from, but someone was giving away generics free. I'll see if I can find that out. I need to track that down. This is also driven by people paying cash. If you're in a insurance plan that covers prescription drugs, you don't care about that. You'll pay your copay. It doesn't really matter what the cost is. The cost to you is the same regardless. So your generic drug copay may be $5, but it's only costing the pharmacy $3. What sense does that make? Once you know what the price is, then you're going to start shopping around. The growth of medical tourism and physician-owned specialty hospitals. One of the things in America, hospitals are not under enough competition. Too many hospitals are in monopoly or near monopoly positions in their communities. The past two towns I've lived in were both one hospital towns. They can do what they want. They're monopolies. And they support their monopolies through programs like Certificate of Need, which require bureaucratic approval of any new facility coming into the town. Certificate of Need is totally anti-competitive. But as long as that's there, consumers will demand competition. And they will go to India if they need to get competition. And they're doing that in greater and greater numbers. You can go to India and Thailand and Singapore and Korea and and the Bahamas, for that matter, much closer, and Mexico, and get services at 1/10 the price of an American hospital. There is competition, even if it's not in your own town. Wherever there is a market, there will be competition one way or another. And if people have to go overseas to get it, they will get it that way. And then physician-owned specialty hospitals. Again, these are Regina Hertzlinger, the business professor at Harvard, came up with a concept that she called focused factories, and which is a terrible name, but a great concept. She decided that facilities that do one or two things very often, very well, provide much better service, better quality. And she cited, for instance, actually a hospital in Canada that does nothing but hernia surgeries, hernia operations, and it does it very good, very efficiently, great quality, great outcomes. Physician-owned specialty hospitals are getting at that. They're cardiac hospitals, they're oncology hospitals. They specialize in a few conditions. And they are growing where they're allowed to grow. Certificate of need prevents them very often. Converting from employer-based to individually owned coverage, Michael was talking about McCain's idea. A lot of employers have already dropped coverage. They don't have to threaten to drop coverage if McCain's idea comes in. They've already dropped it. But their employees are screwed because they've got to pay with after-tax money to get coverage if their employer decides to drop coverage. It's out of their hands. Someone else is making that decision. Again, other people are always making decisions for us. Now, if my employer is not providing coverage, I got to pay for my own. Why should I lose a tax benefit that's available to employees that do get coverage? It doesn't make any sense. And that's already happening. More and more employers are so fed up with healthcare that they're just dropping it. They're saying, I don't care. I don't care. I don't know anything about it. I don't care anything about it. I'm not going to do it anymore. The growth of information technology, again, as I mentioned, is just exploding. It is just exploding. But it's happening from the bottom to the top. President Bush appointed a health technology czar that was going to dictate from the White House exactly how all this information was supposed to work and set standards of information technology. No, that's not how it works. What works is you try it out on a small scale at the grassroots, see what works well, what doesn't work well, toss out the things that don't work well. The things that do work well will grow and will be adopted, and that's how markets evolve. And that is what is happening. The technology czar hasn't done a damn thing. I mean, he spent millions and millions and millions and millions of dollars studying this stuff and having commissions and meetings, but he hasn't actually done anything. Meanwhile, down here in America, it's happening, and it's happening well. And then finally, rejection of government-run insurance. One of the things Michael mentioned was 1/3 of the currently uninsured are currently eligible for Medicaid or SCHIP. What he didn't mention was 1/3 of those people, 1/3 of the 1/3 that are already eligible, had been on Medicaid or SCHIP within the past year. It's not like they don't know about the program. It's not like they don't know how to enroll. They've been there, they tried it out, and they rejected it. They dropped out of the program within the past year, within the past 12 months. They have rejected government program because they don't find value in it. So they tried it out, and even though it's free, it's not valuable to them. I mean, if you're on Medicaid, on paper, you got these great benefits, but you can't find a doctor that'll see you. What good is that? In fact, they're discovering that in Massachusetts. They got coverage, but they can't get health care services, and that's what all this is about. So that's some of what's going on. And if you want to contact me, we have a weekly newsletter that tries to keep track of all this stuff, and I'd be happy to put you on the distribution for it. And perhaps some of you got some questions. I hope I provoked something.